Great. Well, thank you very much, John, and thank you, Roger and Michael, for inviting me. And even bigger thank you for not inviting my wife, because I would have hated to have heard the presentations about obesity, alcohol, farting, and all these other problems. Anyway, my remit, as you know, is to talk about what's new in atrial fibrillation. And I hope you'll forgive me by beginning with some lessons from history. This, as you may know, was at one time the world's most expensive painting. It depicts Van Gogh's physician, Paul Gachet. It was painted about 6 weeks before Van Gogh died. And I'm showing it to you because you can see in his hand he's holding the foxglove, digitalis, and he'd been treating Van Gogh for this for a long time. And some people believe that Van Gogh had been poisoned by it, and that's why he painted such vivid yellows from the xanthopsia. But whatever, it serves to remind you that at one time, digoxin was the only thing we could give people with atrial fibrillation. And I hope to persuade you nowadays that's something you don't really want to do at all if you can avoid it. Of course, we don't know whether Van Gogh had atrial fibrillation or not, because the condition wasn't even described until nearly 20 years later by this cheerful Scottish physician, James Mackenzie, who at the time was working as a GP in Bolton. And he used to do his rounds in an open-top Bentley wearing a top hat and carrying with him this polygraph that he used to record the heartbeats, and was the first person really to observe the irregular pattern of atrial fibrillation. It wasn't until the 1960s and 1970s that we learned what really caused atrial fibrillation. And I don't want to bore you with complex electrophysiology, but it is important to appreciate that atrial fibrillation is a unique arrhythmia, and that it's caused by what we call macro reentry. To get it, you have to have 6 or 7 circuits within the atria. And that's important because the atrium has to be big enough to accommodate 6 or 7 circuits. Small animals like mice can't get atrial fibrillation. Big animals get a lot of it. Racehorses are very prone to atrial fibrillation. There's a massive industry in equine cardiology trying to sort it out. And this is really important to understand because this is one of the guiding principles of how we manage atrial fibrillation now. And Paul Wood, who is a very famous cardiologist, is reputed to have said to his fellows that atrial fibrillation is the left atrium crying out for help. And that's because he recognized that enlargement of the left atrium, stretch, dilatation, was one of the things that caused or triggered atrial fibrillation. And that's something that we'll come back to time and time again during this talk. It's also clear that once you've got atrial fibrillation, that tends to affect the performance of the heart and cause further enlargement of the left atrium, so-called remodeling of the left atrium. And that's why these Dutch cardiologists are credited with this famous phrase, AF begets AF, a word you only hear in atrial fibrillation and the Bible. But the important point here is that if you have atrial fibrillation and you leave it untreated for a while, there will be remodeling that will make it more and more difficult to get rid of the atrial fibrillation. The surgeons worked all this out quite a long time ago, and there's a very famous surgeon who came from Texas called Jim Cox, who designed this operation called the maze operation. And basically what he did was to sort of shred up the atrium, make lots of incisions and cuts to it, and then sew it all back again. So he would block all these pathways and discovered this was a very good way of terminating and preventing the recurrence of atrial fibrillation. And he made a great deal of money and a great deal of fame as a result of this operation. And I remember him describing it at a meeting about 20 years ago when he famously finished his talk by saying, the best thing about this operation is that no way in the world a cardiologist can do it with a catheter. And that is, of course, completely wrong, because that's exactly what we do nowadays with radiofrequency ablation. And I've just come back from America, and I had the pleasure of sitting next to him at a dinner there. And I reminded him of this, and he said, hell, Nick, I made $300 million before they found that out. So, these are important principles. So remember, enlargement of the left atrium is the key thing, and this macro entry is the key thing to driving atrial fibrillation, which is, of course, very common. We're not actually sure how common it is because it's often intermittent, and you don't know, because it's often asymptomatic, you don't know how many people are actually having atrial fibrillation. But these epidemiological studies show you very clearly that it's extremely common, it gets more common as you get older, and it's more common in men than women. At the moment, there's probably 400,000 men in England who are in atrial fibrillation. The predictions are that the prevalence is going to grow probably by 2 or 2.5-fold by 2050. The lifetime risk for a 40-year-old man is 1 in 4. That's to say, 1 in 4 40-year-old men will get atrial fibrillation at some point in the rest of their life. In general, if you have atrial fibrillation, your all-cause mortality is double that of the general population. It's a major preventable cause of stroke. We reckon that at least 12,500 strokes every year in England are attributable to the effects of atrial fibrillation, and it costs a huge amount of money to deal with all this, about 1% of the NHS budget. And we could do it a lot more effectively and avoid a lot of these unnecessary strokes and mortalities. And what I'm going to do in the rest of this talk is just take you through what I would call a stepwise approach to the modern management of atrial fibrillation. And the 4 steps are to, first of all, confirm that that's what's wrong, and to identify the underlying causes and triggers of the condition, and then to try to attenuate what symptoms the patients may have by either controlling the heart rate or controlling the rhythm, and then finally we'll deal with the issue of thromboembolism. Now, it's important to understand this classification. I'm sure you're all familiar with it. Paroxysmal atrial fibrillation refers to intermittent, spontaneously terminating attacks of atrial fibrillation. These are often asymptomatic, so neither you nor your patient may know that they're happening. Persistent atrial fibrillation refers to an attack of atrial fibrillation that goes on for a significant period of time, but can be terminated by medical intervention. Whereas permanent atrial fibrillation is what it says on the tin. It can't be corrected, the sinus rhythm cannot be restored. And of course, it is well known that people sometimes begin with permanent atrial fibrillation, possibly because there's been a silent period of paroxysmal atrial fibrillation leading up to it. But these conditions are, to a certain extent, interchangeable, and patients will shift from one to another. But in general, you begin with paroxysmal, move on through the thing until it becomes permanent. There are a list of causes of atrial fibrillation that are as long as your arm. I've listed some of the common ones here, the common theme being that almost all of these cause enlargement of the left atrium, and you'll remember from what I said earlier, that is an important factor. But we do often see atrial fibrillation, particularly in younger people, where there doesn't appear to be any structural heart disease or enlargement of the left atrium. About 50% of all men with paroxysmal atrial fibrillation and 20% of those with persistent or permanent AF will have structurally normal hearts on echo. And they present a slightly different problem to people who have atrial fibrillation in the context of coronary disease or hypertension. Now, this slide doesn't show 2 of the more important causes of atrial fibrillation in men, which you will see illustrated on this video.
Football tumblers. Oh, yeah, decent height. Not bad. Any more than one's just showing off. Yeah. When you're in a rhythm.
There aren't any Chelsea players in this.
Yeah, the front one, not bad. Celestine Babiera, he does it for assists.
Broke his ankle recently.
Yeah.
Doing that.
This is the one, the front. Oh no. I like it when he does the front one. Oh, this is the best ever, ever. Never spilled a drop. Never spilled a drop.
Now, I'm sure you all know that alcohol is an important cause of atrial fibrillation. And this association was first described in Acapulco, where the cardiologist there became aware that they were admitting a lot of graduate students who'd come down to celebrate passing their exams and had gone into atrial fibrillation, having celebrated in the bars and nightclubs of Acapulco. I thought of illustrating this with some pictures from Roger Kirby's Stag Night, but when I got them out, they seemed to be out of focus. The thing you probably aren't aware of is that atrial fibrillation is an important feature of athletes' heart. Now, elite athletes develop 2 problems with their heart. The first thing is they get left ventricular hypertrophy. The ventricle gets thicker, that affects diastolic function. That can then lead to enlargement of the left atrium. And as I've tried to explain, that can then bring on atrial fibrillation. It's interesting that athletes who spend a lot of time exercising when they're in a sitting position, rowers, cyclists seem to get more left ventricular hypertrophy. We think possibly because they kink the femoral arteries when they're exercising. That increases the afterload on the heart. The other thing is that they get a low baseline heart rate, and that's particularly so in people who do endurance sports like triathlons, marathon running, cross-country skiing, and so forth. And as these people get older, the baseline heart rate tends to get slower and slower, sinus node function deteriorates, and they can become very prone to atrial fibrillation. There was a lot of this about this at the recent European Society of Cardiology meeting in Paris, and here's one of the better papers that was presented there based on analysis of almost 500,000 people in Norway according to their exercise habits. And you can see that men who undertook hard exercise were almost 3 times more likely to have atrial fibrillation than those who undertook moderate exercise. Interestingly, the same association is not seen in women, almost certainly because men approach these things in a slightly different way, as Roger explained at the beginning of the session. The good news is that atrial fibrillation associated with exercise and atrial fibrillation associated with alcohol in general carries a much better prognosis than other forms of atrial fibrillation, because it doesn't carry the connotations of underlying coronary disease or hypertension. And I think that explains why we see that the all-cause mortality for atrial fibrillation in men tends to be rather less than the all-cause mortality for atrial fibrillation in women. Now, once you've diagnosed it and identified the underlying causes and potential triggers, you then have an option of treating the patient with the intention of keeping them in sinus rhythm, so-called rhythm control strategy, or accepting the atrial fibrillation and controlling it and minimizing the complications to the best of your ability. Clearly, if you're dealing with paroxysmal atrial fibrillation, the logical thing to do is to try to maintain the normal rhythm. And if you're dealing with permanent atrial fibrillation, you've got no option but to simply concentrate your efforts on controlling the heart rate. The difficulty arises in the middle if you've got persistent atrial fibrillation, where you have the option to try and get the patient back to sinus rhythm and keep them there, or just accept the situation and control the heart rate. Now, let me begin by, first of all, telling you a little bit about your options for controlling the heart rate. Essentially, all you need to do is to do something to slow the passage of electricity through the AV node, slow the ventricular response rate to the fibrillating atria. And the drugs that we can use to use that are digoxin, beta blockers, and the rate-limiting calcium antagonists like diltiazem and verapamil. Sometimes these things alone aren't sufficient, and we may choose to ablate the AV node or implant a pacemaker so that we can prevent episodes of drug-induced bradycardia and give higher doses of the things we want to block the AV node. That's a relatively simple process, but what has been in debate is just how aggressive we should be in reducing the heart rate. And that's been answered by this very important study that was published last year. And what they did was to take 600-odd patients with permanent atrial fibrillation, and they randomized them to a lenient rate control strategy where they aimed to get the resting heart rate to less than 110 per minute, so not particularly aggressive treatment, or a strict rate control strategy where the goal was to reduce the resting heart rate to less than 80 beats per minute and the exercise-induced heart rate to less than 110 beats per minute. And the result was that you did better with lenient rate control. That's because the drugs and the treatments that are used to reduce the heart rate caused more problems than were solved by lowering the heart rate. So this is a composite endpoint here: death, hospitalization of heart failure, stroke, embolism, bleeding, all sorts of things. But if you go into the paper in detail, it's quite clear that in the vast majority of cases, you're quite safe leaving the patient with a heart rate chugging along around 100 per minute. And you are endangering the patient if you introduce toxic medicines for no other reason than to lower the heart rate. Now, if we want to restore or maintain sinus rhythm, we have to use a different pharmacopoeia, and digoxin is of absolutely no value here. The drugs that are useful for controlling the rhythm, maintaining sinus rhythm, are beta blockers. Many cardiologists like to use sotalol as their beta blocker of choice in this situation because it has properties that are rather similar to amiodarone. In fact, there's very little evidence to show that that is better than a standard beta blocker, and a good body of evidence to show that it can be hazardous and proarrhythmic in some people, particularly women. Flecainide is a class 1 drug that is particularly good at controlling the heart rate or controlling the rhythm in patients with sinoatrial disease and a structurally normal heart. It's very well tolerated. The only problem is that you should not use it in people with established coronary disease because of a trial that was published many years ago that suggested there may be excess mortality in that patient subgroup. And you'll be familiar with the problems of amiodarone. You may have heard of dronedarone, which is like amiodarone, but doesn't have iodine in it, so it doesn't affect the thyroid, has a much shorter half-life, so it's easier to use, and has a greater anti-sympathetic and antihypertensive effect. So it looked like a really good bet. But unfortunately, although it was adopted with great enthusiasm, plugged into all the guidelines in a prominent position, in the last few months there have been some rather worrying publications suggesting that it may be associated with excess mortality, and I think you're going to see the place of dronedarone fall back quite quickly. In deciding which one of these treatments to use to control the rhythm, you need to take account of lots of things. The patient's age is an important factor because I'm quite comfortable with prescribing amiodarone to, say, an 86-year-old, but not to someone who's 30 and may need to take the drug for a very long time, bearing in mind all of its potential side effects, the knowledge that 30% of people who take amiodarone will have to stop taking it because of the serious side effects. Lifestyle is an important issue. People who have busy lives, use their brains at work, don't like to take beta blockers. The triggers are a very important guide to what's going to be effective. Sometimes you'll come across patients with atrial fibrillation who tell you they get it whenever they get excited or upset. That's sympathetic driven. A beta blocker will work very well in that situation. Other people will describe the onset of atrial fibrillation at times of vagal activity, typically in the small hours of the night after a big meal or after indigestion. That's vagally driven. Flecainide is the best drug for that. Structural changes are very important because if the patient has got hypertension or coronary disease, you want to use a treatment that is going to affect that, the underlying pathology in a positive way. And here is an important message. The ACE inhibitors and the angiotensin receptor blockers are much better at reducing the size of the left atrium than beta blockers. This is data from a life study, a hypertension study. It's not really important, but it shows you the effect on left atrial size of patients randomized to treatment with atenolol or losartan. You can see the ARB reduced left atrial size considerably. That is going to be of help in preventing atrial fibrillation in the long run. And indeed, there are many trials of ACE inhibitors that appear to show that they reduce the prevalence of atrial fibrillation in all situations. This has become quite a controversial area because there's been a lot of studies of primary treatment for people with atrial fibrillation randomized to placebo or ARBs that produce conflicting results. But I think the message is that if you need to treat someone for hypertension or coronary disease, an ACE inhibitor or an ARB should be the first thing you think of if they are prone to atrial fibrillation because it will help to reduce the prevalence of atrial fibrillation. The modern term for this is upstream therapy. Now, we've been talking for the last couple of minutes about the benefits of rate versus rhythm control, and there are some randomized trials to help guide us to which is the best option. The best of these is the AFFIRM study, which is a big study, 4,000 people with non-valvular atrial fibrillation, and they were randomized to a strategy of rate control, that's just accept it, slow down the heart rate when they're in atrial fibrillation, or rhythm control, use the drugs I've just been talking about to try to get them back to sinus rhythm. And the result of this is that rate control was better than rhythm control for the majority of these patients. The primary endpoint of survival was not statistically significant, but secondary endpoints like hospitalization were greater in the rhythm control group. And once again, this is because of the toxic effects of the antiarrhythmic drugs we use like amiodarone. So if the patient is tolerating the atrial fibrillation very well, a rate control strategy is in general better than a rhythm control strategy. But not everybody does tolerate it very well. If they hate the atrial fibrillation, there may be something to be said for trying to maintain the normal rhythm. We also need to remember that this trial was published in 2002 and was essentially a trial of antiarrhythmic drug therapy. And we have another option now, technology.
bought something from you last week, and I'm very disappointed.
Oh, yeah? What's the problem?
Yeah, well, my BlackBerry is not working.
What's the matter? Run out of juice?
No, it's completely frozen.
Oh, yeah, I can see that. I'll tell you what, let's try it on orange.
That's got a few black spots, you see.
Oh, dear, yeah, sorry about that.
Yeah. Was there anything I do to get my BlackBerry working?
Well, it could be an application issue. But where do you store that BlackBerry?
It's on my desktop.
Well, you could try using a mouse to drag the BlackBerry to the trash. Then after you've done that, you might want to launch the BlackBerry from the desktop.
Well, I've already tried that a few times. I mean, all it did was mess up Windows.
Well, it might be worth waiting a couple of weeks. They got the latest BlackBerries coming in then.
Well, could you give me a date?
Certainly.
Let me put that date in my diary.
Anything else I can help you with?
Yes, I've also got a problem, to be honest, with my Apple.
Actually, this goes on for a very long time. I think, in the interest of time, I've got to stop this. But what I want to talk to you about very briefly is this option of catheter ablation. And this was introduced by a French cardiologist, Hasseguet, who was the first to realize that atrial fibrillation is usually triggered by an ectopic beat that comes from somewhere near one of the four pulmonary veins. And essentially, what he devised was a method of ablating the tissue around the pulmonary veins as they come into the atrium, isolating them from the rest of the atrium, and went on to show that if you did this, it eliminated atrial fibrillation in a high proportion of patients. Now, it's quite difficult to interpret the literature here because there's obviously a lot of publication bias. People tend to publish good results and keep quiet about their bad results. But there is no question that in selected patients, radiofrequency ablation is a very effective way of treating atrial fibrillation. I don't expect you to read all these, but here's a summary of the major studies on radiofrequency ablation. And it's important to appreciate that almost all of these studies were carried out on a relatively small number of patients. They were virtually all on people with paroxysmal atrial fibrillation and largely people with structurally normal hearts. And the success rates were roughly around 70 to 80%. And by success, they mean the complete abolition of atrial fibrillation with no antiarrhythmic therapy. So this is quite a good option for young people with paroxysmal atrial fibrillation and a structurally normal heart, and that is exactly the place that it has in the ESC guidelines. So lastly, for 2 minutes, let me say a word about thromboembolism. Now, 30% of emboli that leave the heart go to the brain, and we believe that in England, at least 6,000 men have an AF-related stroke every year. All of these things are potentially avoidable if we knew they had atrial fibrillation and anticoagulated them. And you will know that there are many studies that have shown that in non-valvular atrial fibrillation, treatment with warfarin as opposed to either aspirin or placebo substantially reduces the risk of thromboembolism. You will also know that there are many risk factors associated with the risk of embolism that can help you decide which patients have most to gain from anticoagulation. This is the CHADS-2 score, which has been in common use for a long time. If you have a score of more than 2, you should definitely be on warfarin. If you have a score of 1 or 2, you're kind of in the grey zone, and you have a choice which you need to discuss with the patient, should they be on warfarin or opt for maybe aspirin or placebo. Most people actually have a score of 1 or 2, and for that reason, we've introduced the CHADS-2 VAS score, which gives you slightly wider separation of that intermediate group and helps the decision-making process. That has to be balanced against the knowledge of bleeding risk, and again, it's quite useful to quantify this, and you may be familiar with the Hasbled score, which allows you to calculate whether the patient is at high risk of bleeding that go on to warfarin. That said, we do this very badly. This survey data is quite old, but I know the survey is being repeated, and I don't think it'll show anything different now. What it shows is that a high proportion of patients who should not be on warfarin are receiving warfarin, and a very significant minority of patients who should be on warfarin don't receive it. And that's no news to you, I'm sure. Why? Well, it's inconvenient. You don't like prescribing warfarin, having the patients back. Patients don't like it either. I think many people perceive the hazards and risk of warfarin being far greater than they are, but I think the most important factor is that there is no obvious gain. You never knew if you did the right thing. No patient is going to come into your surgery tomorrow and say, thank you very much for putting me on warfarin last year, otherwise I would have had a stroke last Tuesday. They will come in and tell you that grandma's in the hospital having a major hematemesis because you put them on warfarin, or that she's had a stroke because you didn't put them on warfarin. So there's no positive reinforcement here. And that, I think, is a major reason why we don't use warfarin as much as we should. Another problem is that when we do use it, we don't use it very well. This slide shows very nicely the importance of keeping people in the therapeutic range between 2 and 3. Below that, the risk of embolism rises steeply, and above that, the risk of bleeding, particularly intracranial bleeding, rises steeply. Yet, we're not very good at doing that. Only about 50% of people on warfarin have what is termed good control in real life. So the advent of a warfarin alternative is very welcome, and you've probably heard about these new oral 10A inhibitors, apixaban, dabigatran, rivaroxaban, all very promising drugs. They're oral agents, with the exception of dabigatran, once daily. They have a much more predictable effect than warfarin. You don't need to monitor, and they have far fewer interactions than warfarin. And there's plenty of trial evidence to suggest that they are better than warfarin. This was the first of these big studies, the RELY study, that compared 18,000 people with non-valvular atrial fibrillation at moderate to high risk of stroke, randomized to either standard warfarin or low-dose dabigatran, 110 milligrams twice a day, or high-dose dabigatran, 150 milligrams twice a day. And you can see that the dabigatran produced better outcomes in terms of stroke or systemic embolism, and also better outcomes in terms of bleeding. I think this is quite a neat trial because they chose these 2 different doses. And essentially, you can summarize the findings by saying that if you take the low-dose dabigatran, that is as effective as warfarin, but produces less bleeding. And if you take the higher dose dabigatran, it is more effective than warfarin, but produces the same amount of bleeding. And I quite like that option. Rivaroxaban has also got very good trial evidence to show that it reduces the risk of stroke, although not a very big difference in the risk of bleeding. And most recently, we've seen these trials of apixaban that were presented just a few weeks ago, showing that this drug reduces both the stroke risk and the bleeding risk. So this looks like a winner, because it's a once-daily drug, and I suspect that of the 3 drugs, this is the one that people will want to use most. But everything is going to depend on how these things are costed. So in summary, I hope I've been able to persuade you that atrial fibrillation poses an important threat to men's health, and that the morbidity and mortality associated with it can be substantially reduced if we go about treating it in a rather better way than we have done in the past. Thank you very much for your attention.